First of all, if you're wondering if this is a colon-healthy lunch, the answer is yes and no. We'll figure that out together. So this cartoon I like a lot. It kind of sums up, I guess, what everyone feels like at age 50 when they go and see their primary care doctor and they want to talk about anything else except the dreaded colonoscopy, which is coming up. Show of hands, if you don't mind sharing. Who in this room has had a colonoscopy before? Almost everyone. Okay. Anybody pre-contemplative? No hands. Okay. So this is a crowd that knows from their own experience some of what I'm going to be talking about today. If you've had your colonoscopy a while ago, you may learn something new today about the actual experience itself. But since March is Colon Cancer Awareness Month, we felt that it was fairly strongly that we should do this talk and sort of talk a little bit about why we're doing this, what's going on with colon cancer, and then a lot of the talk will focus a little bit on colonoscopy, and I'll try not to bore you since you're all experts. In general, in life, how to increase your odds of survival or to avoid hazardous behaviors and embrace beneficial ones. So, avoid smoking, avoid tornadoes. At least we didn't serve that for lunch. And embrace things that are good for you, like fruit and working out and coming to talks about the colon. So let's talk a little bit about anatomy to start. The anatomy of the GI tract is one of the reasons why I became a gastroenterologist. The more I learn, the more fascinating this subject becomes, and really the exploration hasn't stopped. And while we know a lot about the anatomy, we're just starting to uncover a lot about the physiology and how this thing actually works. And I'll tell you all a secret. The gut is a terrible design. When God comes up with version 2, I hope it works a lot better than version 1, because everybody in this room has had trouble with their gut before. I don't even need to ask for a show of hands. We've all had trouble with our guts before because it's prone to trouble. So the large intestine, or the colon, is mainly responsible for storing waste, absorbing water, maintaining the balance of water in your body, and then a little bit of absorption. But by the time things hit the colon, most of your absorption is already done. So we, in the field, break this up. It's really one organ, but we break it up into its parts. So there's this ascending colon here on the left side of your screen, and that little thing dangling off of it, the appendix. Some of us have ours still and some don't. There's the middle of the colon, which we call the transverse colon. There's the descending colon and the sigmoid colon, and then the final resting place of stool, the rectum. So what is colorectal cancer? Before we get to that, this is another cartoon that I like. We've all felt like this at the doctor's office too. Colon cancer is cancer of this intestine, of the large intestine. Rectal cancer is cancer of the last several inches of the colon, but the rectum is technically part of the colon. So they've been used interchangeably. It's been called colorectal cancer. You've had friends who've said they've had colon cancer and then found out later that it was all in their rectum. And you said, but you said colon cancer, and they were right. Everyone was right. This is very confusing nomenclature. But together, the two are called colorectal cancer. And most cases of colon cancer begin as these little clumps of cells called polyps. And in order to be a precancerous polyp, you're called an adenoma. And there's non-precancerous polyps as well. And we'll talk about that a little later. Over time, these little clumps of cells have the potential to go on and do bad things, which is why we do this screening in the first place. This is the only test that's not only a screening test, but it's a preventative test. Because if we're actually finding these polyps and we can take them out, then we're hopefully preventing a cancer from ever happening. Colorectal cancer is the third most common cancer diagnosed in men and women in the U.S. The ACS estimates that the number of colorectal cancers were 93,000 for this year. This is the estimate, and 40,000 of rectal cancer, exclusionary. So a lot of colorectal cancer in the United States. Luckily, awareness is increasing, right? There's 80 people in this room. There's more funding for screening. State laws are mandating insurance coverage. And this is an old slide because anybody who's been paying attention for the last 2 years knows that under the Affordable Care Act, otherwise known as Obamacare. Now 100% of colon cancer screening has to be covered if it's a screening test. We'll talk about that conundrum in a minute too. Katie Couric did a lot for colon cancer awareness by being bold and having her colonoscopy broadcast in Times Square. National awareness campaigns, endorsement by guideline groups, and basically we're getting better at getting the word out, and luckily, I hope most of us are getting better at providing guideline-driven care and not doing these tests too frequently, but making sure that we're doing them frequently enough. Primary care doctors are nudging patients about it on a pretty regular basis, and so all in all, that we're starting to increase our catch rate. Some of this is redundant, but I will say that the average patient with colorectal cancer death loses 13 years of life. A person at age 50 has a 5% lifetime risk and a 2.5% chance of a related death to cancer. Risk factors are increasing age, underlying conditions like inflammatory bowel disease, which is ulcerative colitis or Crohn's, a strong family history, high-fat diet, obesity, a lack of exercise. That's some interesting and compelling data that's recent. They finally proved that there is a correlation between exercise and development of colorectal cancer, and alcohol and tobacco use. 3 of every 4 cases, unfortunately, are in patients with absolutely no risk factors. So while all these risk factors in aggregate have been linked to colon cancer, you don't necessarily have to have a risk factor to get colon cancer, which is why we're screening the entire population, not just people at risk. So the cause is unknown. Somewhere between the genes that mom and dad gave us, the environment that we live in, our diet, and then these other risk factors, lies colon cancer. It can occur anywhere in the large intestine, and again, it usually begins as a polyp, and most polyps are not cancerous, but over 5 to 10 years, they have the chance to develop into cancer. And now, in the last 5 years, those of us in the field know that there are 2 distinct pathways to colon cancer. There's the 5 to 10 year pathway, which most of these early studies were based on, and there's a very rapidly progressive colon cancer that can come up very quickly, usually right-sided polyps that are very subtle and very difficult to find, and certainly won't be found by any modality other than a colonoscopy, which is the other reason why we're pushing so hard for colonoscopy to be the test of choice, and we'll talk more about that in a little bit. So removing these polyps is the method of cancer prevention. What are the possible signs? Change in bathroom habits. You can have diarrhea and colon cancer. People think that that doesn't make sense. They say, well, why wouldn't it just block you up? But early colon cancer can give you diarrhea, and some of the things that the polyp itself or the cancer itself puts out, some of the humors can give you diarrhea. Incomplete bowel movement sensation, blood in the stool, a frequent reason we see patients with new diagnosis of colon cancers, they start to bleed. Frequent discomfort, gas, pain, cramps, nausea, vomiting. Unexplained weight loss, fatigue, and anemia. And oftentimes I'll see a patient in the office and they'll have 2 or 3 of these, blood, some anemia, some weight loss, some cramps, and unfortunately sometimes those cases end up being colon cancer. Luckily, most of the time they're not. So for those of you in the crowd who've been having those symptoms, you probably don't have colon cancer, okay? The odds are in your favor that you don't, but we want to see you when we need to address the issue. Many, unfortunately, don't have any warning signs. So you're noticing a theme. You don't have to have any risk factors and you don't have to have any warning signs. This is very annoying if you're the consumer, right? You want this thing to declare itself. You want it to put up a red flag and say, I'm here, by the way, and probably we should take care of me. But unfortunately, it's not always that simple. What I tell my patients is look at your bowel movements and pay attention to your body and pay attention to how you're feeling. And don't freak out with every minute change, and try to live a healthy balance of not worrying all the time, but being aware of what's going on in your body. Very difficult task. I'm terrible at that task. So what is screening? Screening is the process of looking for cancer in people who have absolutely no symptoms of the disease. Several different tests can be used to screen for colorectal cancers. I'm going to go through these tests with you guys. So when should we get screened? So 9 out of 10 people affected are 50 years or older, which is why the U.S. Preventive Task Force decided that age 50 would be the age. There is a normogram, there's a curve that begins to go up somewhere around age 50 and steadily climbs through the rest of one's life of your risk of colon cancer, which again, 1 in 20 in your lifetime. It's still fairly low risk, but that curve begins to diverge from the norm around 50 years old. Therefore, screening should start then, and several detection methods, again, are available, and I'll go over them in a minute. Less than 50% of Americans over age 50 are being screened as recommended, and it's not because they don't know about it or because they don't have insurance or necessarily because a doctor hasn't told them. In a lot of cases, it's because the last thing someone wants to do on a Tuesday morning is come and see me. And I don't take offense to that. I get it. But we're going to talk about how important this is. In fact, by the show of hands, I think you all already know. I'm preaching to the choir. What we want to not be is this guy. I love this picture. I love his facial expression. He is convinced that he's going to put that fire out. I'm betting against him. It looks like a nice 4-alarm fire. I don't know what he's doing there. But we want to prevent 4-alarm fires before the blaze, because it's oftentimes the oncologists and the gastroenterologists, if we're looking at a big mass, we feel like we're throwing a bucket of water on a fire. Okay, so screening is to try to prevent the fire from ever starting. Adherence rates to cancer screening are great for breast cancer. Well, I wouldn't say great. It's probably over 73% now for breast. 86% for cervical cancer, and that's only because primary cares and OBGYNs do this. They say we're going to do this, and they do it right then and there. So they got their patient trapped, so they can't get out. Yeah, prostate cancer screening, same thing. I think the rates are high because people actually go to the doctor, so when they're there, they get their rectal exam. But this test of mine requires a whole bunch of steps, right, before you show up. And a bunch of them are on you, on the patient, to do the preparation, to schedule it, to make sure you have insurance approval, to get your ride, to get your ducks in a row. And therefore, you can see that a lot of these people fall off before they ever come in. We're working on it, but it's just a sad truth. By the way, if you look at the 63% adherence rate was in 2003, and the 45% adherence rate here was quoted in 2002. So these were done right around the same time. A more recent study, and I didn't put it in the slide, shows about 44% adherence rate. So here we are now, 12, 13 years later, and nothing's changed. So let's talk a little bit about these tests. Sorry that got cut off there. But basically, there's 3 different categories for screening, ways to be screened. So the first are the radiologic tests. So there's a barium enema. This used to be used with some frequency back in the day. It can usually view the entire colon. It's relatively safe. It can be done every 5 years. And basically you get an enema of barium, and then you go under an x-ray machine and you get some photos taken of the barium inside your bowel. And they basically let the radiologist look at the barium, and they get a nice look at the lining of your colon, and they kind of do an elimination study, and they see what's different, what looks a little bit abnormal, and they can detect polyps with some regularity that way. But it really isn't good for detecting flat lesions, and small lesions. And you need to do a full bowel preparation anyway, and unfortunately, stool is quite adherent and can look very much like a polyp, so there's a high false positive rate. So colonoscopy is also going to be needed if this is abnormal. And then there's the CT colonography, which I'll go over with you a little bit more in detail in a minute, but it's fairly quick and safe. It can view the entire colon. It can be done every 5 years. No sedation is needed. Again, it can miss small polyps. You need to do a full bowel preparation anyway. You cannot remove polyps when you see them because this is an imaging study. And colonoscopy is going to be needed if this is abnormal, because if they find a polyp, they're sending you to me. And then you're going to have to do this all again. Insurance some insurances take issue with virtual colonoscopy. And I usually reserve this study for rescue colonoscopy. If I can't finish a colonoscopy because it's technically very difficult, those patients get a same-day CT colonography. We send them to Portsmouth, which is the closest hospital that does it. And we have a little deal with their radiology department, which is whichever patients we send for this reason are going to have it done. They're the next case, unless there's an utter emergency. So that you as the patient don't have to go home, re-prep, come in on another day. You're already prepped, you come in, you get this done. There's quite a bit of air put in the bottom for this test. I don't know if anybody here has ever had a virtual colonoscopy. It's quite uncomfortable. All the merits of a colonoscopy as far as sedation and taking out the air when we're finished are gone, are lost. So you end up blown up like a balloon. You get exposed to 165 x-rays worth of radiation. But, for some people, this is the last resort, and it's not a bad one. And probably once a year I send someone for a virtual colonoscopy. Then there are the stool tests. Now, these are pure cancer detection tests. These do not find polyps. So that benefit of prevention that colonoscopy offers is lost on these stool tests. The stool tests are twofold. There's the blood test, and then there's the immunochemical test. And there's a variety of immunochemical tests, and some of them are very accurate for detecting colon cancer. The problem is you've already got colon cancer by the time you're using this test. So whether or not it's an early cancer or late cancer, this test doesn't distinguish. So as far as my perspective, these tests are a little late to the party, but they're very useful for some individuals, people who don't want to have a colonoscopy. We'd rather they get something than nothing. So you might be getting annual blood stool tests at your doctor's office, which have a very high false positive rate. If they're positive, you're going to have to come for a colonoscopy. I had a lady in my office yesterday. She had a colonoscopy 6 months ago. Her primary care did a stool test, and it was positive. Her colonoscopy was normal. How annoying. Now I'm stuck with this data. And I said to her, the chance of you having a big fulminant colon cancer 6 months later is basically zero. But, I'm stuck with this data. So we're not doing another colonoscopy on her. But a colleague of hers had one 3 years ago and came in the office, had normal colonoscopy, and she had a blood test that was positive. Same scenario. 3 years felt a little long to me, right? That seemed like more time on the clock. So we did a colonoscopy on her and found her hemorrhoids and nothing else. But at the end of the day, what I tell my primary care doctors is pick your modality. Do a stool blood test or do a colonoscopy. You probably don't need to do both, because the problem is with the false positives, we're going to get stuck with individuals who recently had a colonoscopy and now have a positive blood test. That can be very difficult to interpret. The immunochemical tests aren't so difficult to interpret because the false positive rate, while they can produce them, is lower, especially with the newer tests, which are really geared towards markers that are put out by the tumor. But again, if it's abnormal, you're going to need a colonoscopy. So if I poll the crowd and I say, do you want a test that doesn't take things out before it develops into a cancer, but only finds it after the cancer exists, versus the one that takes out the things before they grow into it, most people would say they'd rather have the preventative screening test than the one that just finds it once it exists. But you know what? Colonoscopy is not for everyone. We recognize that. And for some individuals, depending on their age, their background, what's going on in their life, and where they are with their financial situation and their insurance, these non-invasive screening tests can be very useful. And then, of course, there's a colonoscopy and the sigmoidoscopy. And I'll show you a diagram in a minute showing how far a typical flexible sigmoidoscope goes versus a colonoscope. The real difference between these tests from your standpoint is ease. The night before, anybody who's gone through a prep for colonoscopy knows, is not the night of your life. Flexible sigmoidoscopy, we get away without that night of torture. Okay? So we give a couple of enemas on the day of the procedure, a little milk of magnesia the night before. People actually get a good night's sleep, and they come in, and we do this. And we do this in the office without sedation, and we do it at the hospital with sedation. Dealer's choice. There's a difference sometimes in cost to the consumer, so some people like the office ones, believe it or not. And it's considered a reasonable modality of screening by some of the societies. My personal stance, and those are the nurses with whom I work at York, is that we find right-sided polyps every single day. So if I had done a sigmoidoscopy on the people I'm taking right-sided colon polyps out of, where the sigmoidoscope wouldn't have found them or gotten that far enough, it doesn't make sense to us that this is a acceptable screening test. But the data doesn't lie. Sigmoidoscopy saves lives. A lot of colon cancers are left-sided. It finds those polyps. It finds those cancers. It's very good at that. And then there's sort of the gold standard, which is the colonoscopy, which we'll go into a little more in detail in a minute. The downsides of colonoscopy are obviously that night before. It's a little bit more invasive, so the risk goes marginally up, and it's more expensive. Now, luckily for screening purposes, as we discussed, this is now free. So the more expensive shouldn't be an issue in 2015. When I wrote this slide in 2014, it was still an issue. And for some people who haven't taken advantage of all the insurance benefits of the Affordable Care Act, it may still be more expensive. So direct evaluation of the inner lining of the colon with a flexible tube is the definition of a colonoscopy. It allows for biopsies, removal of abnormal tissue, polyps, for example, and modalities to stop bleeding. Don't think of me as a proctologist, think of me as colon tech support. The green line is the end of a typical sigmoidoscopy. The yellow line is the end of a typical colonoscopy. Okay? So we're missing a lot of colon with a sigmoidoscopy. If you're gonna have to give yourself enemas, come in, get a ride, get sedation, be annoyed by my bad jokes. You might as well get the whole Megillah. But that's the gastroenterologist's view of the world. And not everyone sees it that way, and that's absolutely fine. But everyone who put their hand up sees it that way, so I've got a very friendly crowd on my side today. And this is normal. So when I see a colon that looks like this, I wonder if the patient ever ate. This is as good as it gets. That's textbook. Those are lovely vessels, and that's sort of the tunnel where I dig for half of my day every day. I dream in colons. It's really bizarre to have my job. It's very, very strange to be me. But this is actually a beautifully prepped colon, and you can see with your untrained eyes that you're getting a great view here of the walls of this tissue, and that if something were sticking out of that, even a subtle something, that it wouldn't take too many of these before you'd begin to say, that looks different, that looks different. And that's my job, right? I'm trained to see what looks different and what doesn't. Problem is, everybody's normal is a little different too. So that's the nuance of doing colonoscopy. But I wanted to give you guys a couple of pretty cool pictures to show you some of the tools. We have 100 some odd tools that we can put down this thing. So the colonoscope itself has several channels for instruments. And so this is sort of endosurgery. So we have needles that we can inject underneath things. We can lift them up and we can pull them out with snares. We have special tools that help remove pieces once they're taken out. And then there's actually a real photo there, and it looks a little nebulous, but that's a polyp being lifted off the surface of the colon wall and cut out. Because humans don't have nerves inside the lining of their colon, the discomfort from a colonoscopy is from the pushing and from the stretching and from the air. But when you wake up after even a lengthy procedure, if I take out 32 polyps like I did on an individual last week during one colonoscopy, she had absolutely no pain when we were finished. Okay, she ate her muffin and left, and so happily. But the take-home message is that we can do these endosurgeries most of the time without causing much harm. And this is sort of a more up-close shot of a typical kind of what we call pedunculated polyp. This guy's on a little stalk, looks like a little tree or a little mushroom. And the most common tool that we use to take these out is this little snare, my love of the Wild West. And we put the snare around the base of this, and whether or not we use a little cautery or not depends on what it looks like. But there on the right there is a picture of a polypectomy I did. I'm putting a snare around a polyp and I'm cutting it off with a little bit of heat. The polyp comes out, and we retrieve it, and then we send it to pathology, and then they tell us what that was. And sometimes if it's a polyp that large, like the one I just showed you, we need to tattoo you so you can join a Harley-Davidson troop. And so we can inject, and this is another one of the tools that we use. So you can see that, using this piece of equipment, we can visualize, we have suction, we have air, we have water to spray at things, and then we have channels for all of our tools and equipment. I'm a young polyp. I've got my whole neoplastic transformation ahead of me. Don't snare me. I swear I'm benign. Luckily, they don't talk. So risks of colonoscopy. Everyone wants to know, well, you make this sound like it's the greatest thing since sliced bread, Hyatt, but my friend, right? So everyone's got this friend who had this horrible thing happen. And horrible things can happen. This is we're going 4.5 feet inside the human body with a piece of equipment that wasn't, we weren't designed to have that there. Bleeding happens in about 5 in 1,000, and I can tell you that bleeding in the absence of a lot of work done by me, a lot of polyps taken out, is extremely rare. We've gotten very good at taking people off of their blood thinners before we do these procedures, which really helps to mitigate the risk of bleeding. But bleeding can happen, and spontaneous bleeding can happen. Perforation of the colon is everyone's nightmare. No one wants to wake up and hear, I think I put a hole in you. The good news is that the vast majority of these perforations are quickly identified and quickly fixed. And the fix, if it's a surgical fix, which it doesn't always have to be, believe it or not, but if it's a surgical fix, it's usually a laparoscopic, very quick surgery that goes very well for the vast majority. So you're talking a 1 in many thousands risk that's fixed quickly in most cases. But this is not a perfect science, and these perforations can happen. It feels terrible when they happen to you and you're the endoscopist. I'm sure it feels even worse if you're the patient. And then we can miss lesions, where, according to the data, 90 to 95% successful in finding cancers and precancerous polyps. While the flip side way of looking at that is that we're missing 5 to 10% of these, right? So that seems like a really high number. And I'll show you some data in a little bit. When you look at the colon cancer rate in the last 10 years, since colonoscopy has become the mainstay in, recommendation, it's down 50 to 67%. The cancer is down 67%. This is the only cancer that's down, let alone by more than half. So we may be missing, we may not be doing a perfect job. I'm sure we can get better at this over time, and we have ways in which that we will. But the data is not bad. And you have to remember, despite all these risks, you got a 1 in 20 chance of colon cancer. So if I give you on one hand 1 in 20 colon cancer and on the other 1 in thousands risks of the procedure, most people take the risk. So let's just talk for a few more minutes about virtual colonoscopy.
Do you dress like that?
I don't. Sorry.
I couldn't resist.
I got a feeling there's a couple nurses in the corner that are going to prank me, however. So full prep is still required for a virtual colonoscopy. So anybody who thinks they're off the hook from that horrible night, if they go for a virtual, nope, sorry. There is no sedation, which some people see as a plus, but I'm telling you, it hurts. Everybody who's had one of these things gets blown up like a balloon. There's poor accuracy for medium-sized polyps or smaller. You can't remove anything because that's not what they're doing, and most appropriate for incomplete or high-risk colonoscopies. And, they don't usually make these unbelievable 3D maps, but, using the software that's out there, you can even make a 3D map of the inside of someone's colon, which is absolutely amazing. But I'm just not sure of the utility for general screening purposes. So who should be screened? Absolutely everybody. In my opinion, there's no reason why people shouldn't be screened in one way or another using any of the modalities that we discussed today for colon cancer. The average risk individuals should begin at age 50, and those with an increased risk factor may be screened sooner depending on their family or personal history, symptoms, pre-existing conditions like colitis, which we mentioned before, which increases your risk of colon cancer in some people. So I just want to give you an example of some of the minutia that lives in my brain. This is my job, not your job, to know all this. And this is, there's pages and pages and pages of this stuff because it goes on and gets more and more complex. But I just want to give you an example of some of the complexity. If you have a single first-degree relative, that's children, sisters or brothers, or parents, that's a first-degree relative, who had colon cancer, then, and it was less than 60 years old, or 2 first-degree relatives with colon cancer or advanced polyps, the recommended screening is every 5 years beginning at age 40, or 10 years before the age that they were diagnosed. So if dad had colon cancer at 38, I've got a couple of these in my practice. We start colon cancer screening at 28 years old, and we do it every 5 years for the rest of their life. Even if they got mom's genes, we'll never know. But it's a several-fold increased risk to those family members. And so what we don't want to do is let them not be screened until 50, because all the data shows that there's a high risk in that population of a young cancer if it was a young cancer in that family member. That's just one piece of the pie. And I'll give you an example of how complex this gets. I'll go off script for a minute. Of the 2 family members with colon cancer, let's say one was 28, but it was an uncle, and the other was 60, right? I'm supposed to start in that patient at age 40, okay? But I had a girl who had 3 uncles and aunts, all diagnosed with a young colon cancer, all before the age of 40. So what did I do with her? Well, there's no guideline for her. She's off script. So what I did on her behalf is I sent an email to every single gastroenterologist in every position of power that I possibly could. I got 17 opinions from all my friends at academic institutions all over the country, and about 13 of them gave me the same opinion, and 4 dissented, so I went with the crowd. But sometimes these things require just some nuance, some thought, general opinion from the crowd, and that's what expert opinion is. So I got her my own guideline. I got an expert opinion panel for her. But, at the end of the day, a lot of the time we're making an educated decision, and most of us who do this for a living would rather err on the side of caution than wait too long to do a screening in someone who we consider high risk. What to expect the day and night before your colonoscopy? It's kind of the perfect monk's picture. I mean, he must have been prepping. So, to get a good prep, first of all, before we go into this, you really want to avoid nuts, seeds, raw vegetables, corn, and popcorn for 3 to 7 days. This is in the fine print, but nobody reads it. So I find everybody's nuts, seeds, vegetables, popcorn. And that's fine. We can deal with that. It usually doesn't cancel your procedure, but it certainly makes it an annoying one for me. Hydration with Gatorade or sports drinks is key. And I added this, don't go into a prep constipated. People forget when they schedule a colonoscopy to mention that they're super constipated type and they only go to the bathroom once a week. And if that's you, there's lots we can do about that. We can start your prep a little earlier. We can get things moving with some gentle laxatives, not horrific laxatives, for a couple of days leading up to it. So when I'm lucky enough to catch someone in my office and we can have this discussion, we set it all up for success. The problem is some people don't realize that the prep won't work if you're going to try to prep bricks. And so they come in and they're poorly prepped. And that's very unfortunate because then I'm telling those people that they have to do more and they have to come in again tomorrow. And nobody likes me when I say that. So that's not common. We've gotten much better at this. I think people have gotten better at prepping, and we've figured out the tricks and what we need to tell people and keep hammering home so that they do this appropriately. That's a pretty good prep. Not quite the perfection that we saw before, but that's pretty good. But these are the alternatives. Sorry, I'm showing you poop during your lunch. But, on the left is sort of a liquid slurry. I can probably take care of that with suction. On the right, we're starting to get a little more solid. I can probably take care of that too. And I did not send you the worst case scenario because you just need to look in the toilet. Because honestly, I go into colons sometimes and that's what I see. And there's nothing I can do about that to help that person on that day. This is the most dreaded part of the process. You're going to have a ton of diarrhea. About 4 times a year when I'm on call, inevitably at 2 or 3 in the morning, I get a call. It's usually from someone elderly who says, I'm having horrible diarrhea. And I say, what time is your colonoscopy? And so people forget that this prep is going to give you diarrhea. And it gives you a horrible night of diarrhea. Luckily, without the fevers and hopefully without the vomiting, although some people can't tolerate that much volume and they don't feel very well. But usually compared to the diarrheal illnesses we've gotten in the Caribbean, a prep is sort of a little bit more of a benign experience. Easy for me to say. Many preps are available. They differ in taste, liquids and tablets, dietary restrictions, when to take them. So depending on which prep is chosen for you, and sometimes that's a negotiation and sometimes it's not, and I'll tell you why. Depending on which prep is chosen for you, there might be a little subtlety in your instructions that differ from somebody else. Let's say your husband who had it a week before. It might have been a different prep. There are preps that are considered safer for the heart and for the kidney. They're more disgusting. So if I ever use the disgusting preps, it's because you have heart or kidney disease. My favorite prep is a Gatorade and Miralax, which tastes like Gatorade with a twist because you're going to the bathroom all night. Don't give that one to athletes. And then there's a pill prep, and some people prefer the pills, but they forget that you have to drink quite a bit, still 64 ounces of fluid. So it's the same volume of fluid with the pills as it is with the Miralax and Gatorade. So it's just sort of dealer's choice. So I just went through this. There's high volume solutions like Go Lightly, the worst named product in history. It should be called Go All Night and Be Miserable. There's low volume solutions, which are about half that volume. and some require addition of tablets of laxatives, and then there's the osmo prep or the pill prep. Remember that unlike your other diarrheal illnesses, prep for colonoscopy has no fever. I love giving a talk where I can show you a roll of toilet paper, and you guys just nod along. Yeah. Prep for colonoscopy has no fevers or pain, but you'll spend some time in the bathroom. In fact, you'll spend quite a bit of time in the bathroom, and everybody's going to spend a different amount of time in the bathroom. Okay, some people go 5 times and they're prepped, and they're just extremely lucky individuals. And some people, spend quite a few hours, and that's okay. You're going to get it done. You're going to clean out.
Might want to move those magazines a little further away.
Yes. What to expect the day of the procedure. So you come to our endoscopy unit on the day of the procedure. You'll be admitted to a private room. I think privacy used to be a bigger deal. Anybody who had a colonoscopy maybe more than 10 years ago in the room may remember like a thin curtain separating you from the person next to you. That there are still units, freestanding units, where this happens. We really have been working as a medical community on privacy. We don't want you to see your neighbor, Bob. We know how embarrassing it is for both of you when you see each other under my care. So we've really tried to keep this as private as we can. You're going to get an IV in your arm, and that's the last annoying thing of the day. You're going to meet the doctor and sign a consent form. You're going to get some sedation through the IV, and then you're going to have the procedure. After the procedure, you're going to have some recovery time in the endo unit. You'll speak with us. We'll make sure that you're feeling well. You'll eat something, thank God. And then if it's necessary, we'll wait for a letter to from us regarding pathology and whatever we sent to them. So when are you going to need to come back? So again, this is one of what could be about 100 slides, depending on the nuance of the case and who the person is and what the risk factors are, what we found, where we found it, how big was it the first or second time we found it. This gets very confusing. But in general, if you're normal, you have a 10-year follow-up colonoscopy. Normal meaning no risk factors, no polyps. That's best case scenario. I love it when I get to give that news, but that's rare because about 40 to 50% of people will have a polyp of some kind taken out during a colonoscopy. And of those, about half will be the kind that bring them back in 5 years instead of 10. If you have 1 to 2 small precancerous or adenomatous polyps, the guidelines say 5 to 10 years. We're saying 5 years. That's what we recommend. Nobody's letting those patients go to 10 years, nor should we. If 3 to 10 adenomatous polyps or 1 greater than a centimeter in size, then it's going to be 3 years. So if you've ever had a colonoscopy and been recommended a 3-year follow-up, you probably had either a bunch of polyps or some big ones. And then there are polyps that are a little bit more prone to cancer than others. And sometimes when we send to pathology, they'll tell us, for example, that it was a tubulovillous adenoma, which in English means bad news. So those are patients that we want to see probably in 3 years instead of 5, even if it's just 1. More than 10 adenomas should be done a little sooner, mostly because if you have 10, there's a chance we missed an 11th. Don't forget, we're missing 5 to 10% of these. We don't want to give you 5 years for that to grow. If they're permanently attached and not on a stem, and they're difficult to take out, you may be asked to come back in 6 months or less. That's very annoying. No one likes to wake up and hear me say that either. But the truth of the matter is we're in the business of saving lives here. Those very flat, large polyps tend to be very aggressive. And if we think we got out the whole thing, but we're not sure, we go back in and make sure. So usually those are people who get tattooed at that location, so we can go right back to that spot and look again at that exact spot in about 6 months. And then we'll give you your 3 years from there. And if you're greater than 75 years old at the time of a routine procedure, we recommend that you have a chat with your primary care. And my personal cutoff now is about 80 because we are all living longer, thank goodness. And we're not only living longer, but we're living quite well, okay? Knowing someone in their 90s who kind of like walks themselves around used to be a rarity. Now it's like most of York. So I think that these are wonderful times. I think that medicine is working. I think that doctors' visits, if we look at our population getting older and in general healthier, I think these things are generally working. So my cutoff is 80, and I'm not an ageist. I'm the opposite. I'd like to give people the best chance they can to go to 100, 110. I had one 88-year-old who really wanted a screening colonoscopy. I said, no, you don't. And she said, yes, I do. So I did it, and she had nothing in that. I said, "Are we done, or are you going to see me at 98?" But and again, if someone wants it done and they feel strongly about it, we'll keep screening. Believe me, it's fine with us. But at some point, I think it's reasonable to stop, especially someone who's low risk. While the risk of colon cancer goes up, the risks of the procedure go up, and at some point, people need to stop letting us torture them. So, colon cancer screening is important. It is safe. It's preventable. It's effective. We want you to feel confident in your decision to be screened and comfortable before, during, and after. And the during, that's when I see most people, is the during, and it's really important to me that people come in and leave saying, given the horrific experience that was, it was as good as it could be. That says down. Don't get caught with your pants down. Colonoscopy has risks, but the risks are small compared to the risk of colon cancer. It's not foolproof, but it's the best available test, and it saves lives. So these are the 9 hench people of the apocalypse, and the 3 with arrows are myself on the left, Dr. Flavin, and Dr. Epstein, and we are the York team. But this is the Atlantic Digestive Specialist Group, and we are subspecialty, multi-physician, private practice. We are at 4 hospitals, 2 surgeries, 5 hospitals, 2 surgery centers. Very, very busy. You don't want to be me on call because one of us covers all 4 hospitals at a time. And we love what we do, and we're happy to see you guys anytime. So that's the end of the formal talk. That's my bike. I figured I'd open it up to questions from you guys. Yes?
I wanted to ask about genetic testing.
Yeah.
For colorectal cancer.
A specific question about it, or just in general, what's going on?
Is there,
Yeah.
say, that
So the
young woman with all the relatives?
Yes. Yes, she's had it. So the question is about genetic testing for colon cancer screening. For colon cancer. There are families in whom it becomes blatantly obvious that there's something going on. And we have identified in 2015 several culprit genes that run in families that may predispose you to colon cancer at an earlier age or increase the likelihood of colon cancer. We want to identify these families because oftentimes, if it's some 49-year-old coming to talk about a colonoscopy with me, she's got 2 little kids, she's got a bunch of siblings, maybe younger siblings who haven't been screened yet, and if there's some high-risk gene, I'm talking about saving lives of an entire population here, not just, this one woman. The risks that we look for depend on the family history a little bit and depend on the personal history. Anybody who's had 15 or more polyps, either in the first colonoscopy or aggregate, let's say it's your 3rd and every time we're finding 5. Once you get to about 15, I'm concerned about something called attenuated familial adenomatous polyposis, which is just one of the 50 genetic disorders that we've identified. But if you're getting up to 15 polyps, I'll probably send you to a genetics counselor to be tested for that. By the way, I'll send to a genetics counselor. I'm not sending these tests myself. Here's why. There's a whole nuance to interpreting gene tests. It's not usually just a you've got it or you don't. You may be a carrier for a subgene, and I don't pretend to be a geneticist. I know what these diseases are, and I know when to send someone, but I'd rather the experts weigh in on what to do with the data. So if I'm going to send someone, I usually send them to, there's a Dana-Farber geneticist who comes to Wentworth Douglas Hospital once a month, and so I'll get you into that clinic, and you'll go. Lynch Syndrome is our biggest fear. There are some very strict criterion for what we would send for Lynch, but it's a familial colon cancer syndrome where it goes in hand with breast, ovarian, endometrial cancer, and some other cancers. So if I'm looking down a family history and I'm meeting someone in the office and I see that grandma had breast cancer, uncle with colon cancer, dad with colon cancer, my bells start to ring. This could be a Lynch syndrome family. And that's one cancer that we need to check for because that's actually annual screening colonoscopies for the rest of your life. You need to screen for breast cancer with some regularity. You need to have pelvic ultrasounds. You need to have your ampulla, which is in your small bowel up above, looked at every other year because those are the most common cancers of those patients, and they're very common. 40-fold risk of cancer. So we would like to identify these people, and sometimes we send them to genetics counseling. But those are 2 examples, attenuated FAP and Lynch. of the many for why I would send someone to a geneticist. Yeah. Other questions? Yes.
I've heard that colon cancer is the most preventable cancer. Is that accurate?
Well, based on the data, I'd say so far, yes, because we're preventing it. I mean, we have statistics that show that 67% reduction since colonoscopy. And if you consider this a prevention test by taking out the polyps, I think I would agree with that statement.
And how do polyps get there?
Bad luck. Somewhere, I haven't yet figured out why a smoking 78-year-old obese guy who drinks has like a perfectly clean colon, and his wife is full of polyps, and she's like rail thin and ate everything right and never smoked a day in her life. But I think that we'll probably be able to tease this out soon. But I think genes are playing a bigger role, and actually there's some compelling data that our microbiology, our bacteria, are playing a pretty big role too. So more to come. 10 years from now's talk, I hope, is more interesting than today's.
Now, do you put some polyps in so that you can find them the next
Absolutely. Yeah, we use Elmer's glue. Yes. Yeah.
Can you talk about irritable bowel?
Well, it's not the topic of today's discussion, but do you have a question in specific about that relates to colon cancer, or?
Well, you don't mind, but not okay. You don't want to talk about it, okay.
I probably am not going to launch into a whole discussion of irritable bowel, but I will say this, and I alluded to it earlier, but I think it's an important point. The symptoms of irritable bowel overlap with a lot of GI disease. Chronic constipation, hemorrhoids, which can come from that, blood in the stool, which can result from that. And what I've seen over the years is sometimes patients get pigeonholed as to having one disease when they're allowed to have developed another. So if you are more than several years from your last colonoscopy and you're coming to see me as a new patient and you're having blood in your stool, and even if you say, well, I've bled off and on my whole life, to me, you're bleeding, and if you've been bleeding recently, you need to be thought of as a potential colon cancer screen patient until we rule that out. So there's quite a bit of overlap between the symptoms, and that can be very difficult to tease out. Yeah?
What are the risks of a colonoscopy for a patient, over 75, or in your case, over 80? Why would they not want to do it?
Well, heart disease and the complications of the anesthetic, right? A lot of people have poor respiratory function, kidney disease, because everyone's kidney function goes down over time. So if we're prepping you, we're taxing your kidneys a little bit. The general risks that apply to a 50-year-old just get magnified a little bit as you get older. But frankly, we've been in so many colons of 90, 100-year-olds. I mean, people do fine. The organ holds up fine. The scope goes through it fine. People aren't made of paper, even at that age. But I often take pause before we do a colonoscopy in somebody, quite elderly, and think, is this absolutely necessary? Am I saving a life today? What are we doing? Are we here for good reason? Does the family and the patient understand the risks pretty well? And as long as we've checked all those check boxes, if I can feel good about doing it, I'll do it. And if I don't, I probably won't. Yeah.
Is there any relation between diverticulosis and colon cancer?
There is not. Diverticulosis, by the way, you've all heard of diverticulitis, because maybe everybody in here has either had it or had a friend with it. Probably had a friend with it, because it only affects a very small percentage of the population. That's when these little benign outpouchings called diverticulum, which hang off the colon in 50 to 75% of us in this room, get inflamed or infected. Diverticulosis is just the presence of the pouches themselves, and we find them, like I said, 50 to 75% of colon cancer screenings. You'd never know you had them if we didn't tell you. You'll live and die with them. They won't affect you in any way. Don't avoid nuts, seeds, and popcorn or anything like that. That's a wives' tale. And there's no correlation to colon cancer that we know of. Back.
What do you think about colonics as part of an overall wellness program?
Show me the data that does anything good. I've taken care of 4 perforations from that procedure in my career. There's no evil humor that lives in the colon that needs to be expunged. The body does a great job of getting rid of things itself. There's no data to support doing colonics ever. That's my opinion. Yeah.
If someone has like an extreme with severe constipation,
Mhm.
do those people have more chance to get colon cancer?
It's a really interesting question because, you know, there's certainly some data. I'm going to repeat it.
We turn so quickly.
I thought they liked me, Belinda. Does constipation, you know, beget a risk for colon cancer? There isn't data that constipation itself does, but there is some really interesting data on the microbiology of the gut in a constipated patient, which is altered. I don't think that's been well vetted, to be honest. But as of right now, I don't think so. And if you're a constipated type out there, you're not going to get colon cancer because of your constipation. There's no data to support that in the least. But I'll see you in my office. Yes?
I've had colon cancer twice, and now I'm having a hard time going. Was that part of the problem?
Well, I mean, if you haven't been looked at very recently, right, we would worry about you. You deserve to have, do you have your colon left? Yeah, but you deserve that, whatever's left, to be looked at. And if not, then you're a post-surgical patient, which for anybody who's had a surgery of any kind on any organ knows your whole bowels change after a surgery. Sometimes in some people they recover well. In someone who's missing a lot of their colon, they might not. So I hope you've addressed this recently, and if not, yeah, good.
It's been 7 years since the last time.
Yeah.
And they told me not to come back.
Yeah, please come back.
Calm down.
Because, you know, and this is a great example. First of all, thanks for sharing that, and you're a colon cancer survivor, so this whole talk is on your behalf. I'm dedicating this talk to you. Round of applause, sir. But, and do you mind talking about this, or, I mean, you brought it up, so I'm going to say you don't. Was your colon cancer found on a colonoscopy? Yeah.
Twice.
Yeah. So, patients like you, we don't want you falling through the cracks. Because the cancer got taken out, you found out it came back, which it can't, right? This is the reason we survey colon cancer survivors with a more regular interval. And we never tell them to go 7 years without coming back in. The most we'd probably ever recommend would be 5. If at a certain age, a patient who's 88 or 85 or 81 or 75 or any age they feel like says, I never want to have this again no matter what, and I understand the risks, that's it. They've made a good informed decision. And we're not pushy at that point. But if they just told you don't need one again, I'm sorry you were told that. Come back in the fold. That's not our recommendation.
All right.
Yeah.
How do you select out of the phone book a specialist that's going to do the colonoscopy and know that that person isn't the one that caused a bigger percentage of the perforations? Or
our quality data is not being well kept. In other words, this isn't public knowledge. It's going to be. I think there's been a big push to make all of this public knowledge, and it will be. It's part of what's coming, our quality metrics. The biggest piece of data that's going to be made public is our polyp detection rate. And it's skewed data in many ways, but the polyp detection rate for the precancerous polyps is probably what you should use as your best guide to who's doing an adequate job. The national rate that they quote that we should be finding for polyps is 25% in men and 20% in women, precancerous polyps, on a screening colonoscopy. If your doctor's finding 6%, there's a problem, okay? And if they're finding 50%, they're awesome. And so, you know, it's probably worth looking at that data when it becomes available. But for complications and whatnot, what I would do is talk to your primary care doc and ask them the following question. If you were going to have a screening colonoscopy, who would you send it to? Because don't forget, the primary cares have been around for a while. They know all of our complications. They're on to us because it's all their patients. So, you know, I would recommend that whoever they recommend to you is who you should probably follow the lead of. That's somebody with a nice global perspective, okay? And I'll gladly share my statistics with you anytime because I'm pretty public about my mishaps because they're extremely rare, as they should be. But anyway, that's how, and hopefully most of us would feel that way. Okay? Yes?
I have friends that are into healthy colon and do what you can, and they're into probiotics. That seems to be the rage.
Yeah, no data that prevents colon cancer, but there's lots of data that probiotics are useful in other diseases. I prescribe them a lot. It just depends on the patient and what we're dealing with. So, but for this topic, I as of right now, you know, and there might be more stuff coming, There is not good data that probiotics are going to prevent colon cancer, or obviously it shouldn't be used as a treatment. So if you're going to take a probiotic, don't do it for your colon cancer health. But you could certainly try it for other things. Irritable bowel, there's good data. There is some imaging coming. There's some interesting imaging studies, some MRI protocols that do a stool extraction. In other words, with no prep, they're able to take out the stool and sort of look at the wall of the colon. And if that gets good enough, that could replace colonoscopy. The problem is, what are you going to do with all the polyps? You're going to come and see me. But at least you might get away with no prep for the first round, and then my job will become simply polyp removal in less detection, which is fine. I think it will generate more business for us, not less, because I think it would get more people screened. So I'm hoping that technology comes of age. I hope it's MRI and not CAT scan because of the radiation.
And what do you do with the polyps? The lab looks at them?
Under the Christmas tree. The polyps go to pathology. Did you hear it? The question was, what do we do with the polyps? They go in a specimen jar, and they go to pathology, and the pathologists within 1 to 3 days usually look at the polyps under a microscope, and that's where we discern what are we dealing with. Is this a high-grade polyp? Is this an adenoma? Is it the totally benign hyperplastic polyp that didn't matter? Is it cancer, etc.? So I'm only as good as my pathologists. Yeah.
Why can't you see on the left side as well as the right side?
I can. Well prepped
You
colon.
said that if you had polyps on the left side, they weren't picked up as readily.
The sigmoidoscopy doesn't go to the right.
Oh, but it wasn't the colonoscopy.
No, the colonoscopy does the whole colon. No, that's fine. That's a great question. She wanted to know why we can't see as well on the left, and we see great on the left for both procedures. It's just the problem is the buck stops there with the sigmoidoscopy. So, yeah.
I had a colonoscopy once, and the physician that did it told me she lost one of them.
Yeah, so dropped polyp. The question is, what do we do about it when we have a polyp in it and then all of a sudden it's gone? There's 3 reasons why that happens. The most common is we suction the polyp into the scope and we capture it in a little trap. But the polyps can be very small, and they can actually disintegrate either on route or once they hit the trap. It's rare. It's so rare that we keep using the same technology to do this for most of our cases. But once in a while, we'll look in the trap when a case is done, polyp's gone. So the second reason that happens is it gets lost in a puddle of muck. So if the prep isn't that great, this is another reason why it's a problem. Not every polyp you snip off stays in view. It can disappear. I've gone on famous hunting missions. Some of these nurses have been on them with me for 20 minutes to find the polyp that I took out dangling somewhere. And sometimes we're successful and sometimes we're not. So what we do is we err on the side of caution. We usually consider that a precancerous polyp and bring you back in 5 years instead of 10. Very annoying to be the patient and get told that. But I'd rather be cautious than err in the other direction and find out the hard way that we should have. So that's what most of us do. That's an extremely rare event, by the way. Yeah.
She didn't recommend that I come back in 5 years, but I'd get a couple colonoscopies since.
And you won. It's my pleasure. Well, I think.
always wondered what happened to it.
Last question?
Yes, you mentioned earlier about our lunch.
Yeah.
Good and bad. Do you want to tell us good food, the bad food?
Yeah. So.
Where is it now?
So obesity has been linked to colon cancer, and we ate a big carbohydrate-rich lunch, which will just feed the fire. However, it was also rich in protein, and I didn't see a lot of fiber in there, but I saw a little. The only food that's been linked potentially to colon cancer prevention is fiber, and the only medications that have been linked to colon cancer prevention are low-dose aspirin, interestingly, and there's been some data for folic acid or folate. That doesn't mean everyone should run out to the pharmacy and start popping pills, because these are associations. It's weak data. And I would say, and that's why they're not part of our recommendations. Otherwise, we'd be the ones making those recommendations. But more to come. There might be some polyp prevention stuff coming down the line, I hope, that will help to prevent these from ever forming in the first place. That would be lovely. Thanks so much for letting me drone on.